We have the next lecture is surgery in hemophilia with inhibitor. Is given by Dr. Cecil Ross. Cecil Ross sir is head of the department of medicine, and he is in charge of hematology in St. John's Medical College Hospital, Bangalore. Sir has obtained MBBS from St. John's Medical College, Bangalore, MD from Government Medical College, Bellary, 1996. He obtained his specialty training in CMC, Vellore, and Royal Fed Hospital, London, and St. Louis University, USA. He started his hematology services way back in 1990. And Sir has done a Twin of the Year program by WFH in 2001. And he has got a Glue Grant from DBT for research in leukemia and training mid-career medical faculty. And he's the founder member of Hemophilia Society Bangalore chapter, and is currently the professor of medicine and head of hematology, St. John's Medical College and Hospital, Bangalore. And was the national vice president medical of Hemophilia Federation of India. And his research interests includes recurrent pregnancy loss, thalassemia, and bleeding disorders. Thank you, sir. Over to you, sir.
So, thank you, Chandrakala, for introducing me kindly. So what I will do is I will talk to you on the management of surgery in patients with inhibitor. So what we will start off with is impact of inhibitor development on surgery. We will then move on to considerations of surgery in patients with inhibitor. Then we'll talk about the use of FIBA, Novo 7, and Hemlibra in the context of surgery, and then top it up with the take-home message. So if you actually look at the magnitude of the problem, if you see the total number of patients who actually receive either plasma-derived or recombinant products, either of the two, you have patients who develop inhibitor, something about 15 to 35% across the country, but a large majority of them, 65 to 85%, do not develop inhibitor. So the 15 to 35% who develop inhibitor pose a major problem. And when you have a patient with inhibitor, those 30% or so, if you are a high responder, you cannot give factor replacement because they will neutralize, the product gets neutralized. But supposing you are a low responder, you probably can give a little higher dose, and you can see the cost of factor replacement in patients without inhibitor approximately is 30,000 rupees, whereas with low inhibitors, it goes up to 1.5 to 2 lakhs. But if you have a high responding inhibitor, you have to use either FIBA or Novo 7. And if you use FIBA at recommended doses, it's approximately 6 lakh rupees. And if you use Novo 7 at the recommended doses, it will be about some 11 lakhs or so. So this is the problem of surgery in hemophilia. And therefore, this is a slide that I got from Chandrakala, the data from government of Maharashtra that says the large number of patients in Maharashtra who don't have inhibitor, 4,500 in the database, and only about 150 patients are there who have got inhibitor. Now, if you look at the resources that are consumed, the 150 patients consume about 11 crores for the management, whereas the balance 4,500 and odd people consume only 1.9 crore rupees. So you see the amount of money that goes on if you develop inhibitor. So that's the magnitude of the problem. So just to understand what is the meaning of an inhibitor Bethesda assay. If you have a assay, Bethesda assay of about 1%, it neutralizes about 50% of factor activity. And therefore you can see that if you have say 2% and if you give factor rate, which actually should have been at 100%, you will actually get about 10 to 20% in a matter of half an hour or so. And by the time the factor disappears out of the system and there'll be no more factor. And therefore, if you look at what a clinically significant bleeding, which requires treatment, it's more than 6 Bethesda unit. You have a low titer people and you have a high titer people. The higher the titer, the larger the capacity to neutralize factor rate activity. So that is the importance of understanding the Bethesda assay. So what do you do if you have patients with high titer inhibitor? All doses of factor VIII, whatever given, will be neutralized and the bleeding continues. If you have a high titer that is greater than 5 Bethesda unit, and this patient will have to be given bypassing agent. On the other hand, if you have a low titer inhibitor, and if he's got a high responder, that is, antibody increases after factor 7 infusion, that's an anamnestic response, this person will also have to be given bypassing agent. There's no other choice for this patient. On the other hand, if you have a low responder, that means that there is no elevation of inhibitor titer after giving factor 8. He's a low titer inhibitor, and therefore this patient, you can give a little higher dose of factor 8 and manage the surgery. So what is the meaning of major and minor surgery? Major surgery means an invasive procedure where you actually invade a body cavity, you cross a mesenchymal barrier, or you cut across a facial plane, or an organ is removed. That basically a normal anatomy is operatively altered. And these type of surgeries, you expect it to take treatment for at least more than 7 days or so, and that is a major surgery. On the other hand, if you look at a minor surgery, what is meaning? The meaning is only mucous membrane like oral cavity or skin or superficial connective tissue was manipulated, like for example, dental tooth extractions or endoscopic surgeries, or endoscopic evaluation and so on. And here you don't expect the surgery to, the treatment to last for more than 7 days. So that is the meaning of minor surgery. So just to understand that what is major surgery, what is minor surgery. So when you actually look at patients who you actually consider for, say, elective orthopedic surgery in patients with hemophilia and inhibitor, you have to look at the relevant comorbidities the patient has got, his age, his inhibitor titer, and whether the hospital has got an experienced and multidisciplinary team, and the type of urgency of the surgical procedure. Now, these are all important because depending on the type of surgery, what the patient and the family prefers, and the risk factor for thrombosis. The other issue that you have to decide also is, because all these will determine the cost of replacement of bypassing products is horrendously costly. Like I told you in the previous slide, you have to depend on NHM, World Federation of Hemophilia, Hemophilia Federation India, third-party insurance, and so on. So these are all the things that you have to consider. And of course, in your stock, you should have adequate supply of replacement factor or bypassing products, and you should have both, either FIBA or Novo 7. Both of them you should have just in case you land up in a surgery. And then of course, timing of surgery. Timing of surgery also is important because you ultimately, if it's an elective surgery, you have to plan it preferably in the beginning of the week, that is Monday or Tuesday. You cannot have a person with hemophilia and more so a patient with inhibitor to have a surgery somewhere in the weekend, where the hospital systems are not very optimal, and therefore it's preferable to have surgeries in the early part of the week. As also the timing, in the sense that how emergency surgery and whether you can optimize the products that are there in your stock by postponing or preponing the surgery is all important. So how do you assess the patient for hemostasis and person's hemophilia? You look at the CBC and look at specifically the platelet count. You look at drugs that the patient may be taking, whether they've got an antiplatelet effect. You look at the plasma clotting time, APT, TPT, factor 8, factor 9, and whether the person has got inhibitor, fibrinogen levels. You can also do response recording. We do that sometimes, where you give factor 8 or factor 9 at about 30 to 50 unit per kg, and then we see how much of factor is recovered. And based on that, you can probably calculate what factor you would need for him on day 1 of surgery and a couple of hours into surgery, and then post-op how you manage. So this is somewhat of a rough guide. Then of course you have to look at the viral status, whether the person has got HIV, HBV, HCV, and also what type of anesthesia I would give for surgery, whether it's general anesthesia. And we would normally recommend general anesthesia, and you also would recommend to give tranexamic acid unless otherwise contraindicated. We give normally at about 25 to 30 milligram per kg every 6 to 8 hours. Then the types of surgeries. So if you are actually trying to see whether you can have a reduction in the bleeding frequency and you want to do a synovectomy, you can do either radioactive synovectomy or a surgical synovectomy. If you have contractures, you wonder whether you have to do an extra articular soft tissue release, and that is a different type of surgery. If you do arthroscopy, it's basically to diagnose and correction of adhesions or impingement within the joint. If you have angular deformities, then you want to know whether osteotomy would be beneficial. Arthrodesis of the ankle, where is surgical immobilization of damaged joint. So these are the procedures that you could normally do in orthopedic surgeries and the purpose of doing these type of surgeries. So what are the interventions that you do in a patient with chronic synovitis? You can do synoarthritis or synovectomy, which could be radioactive. In a person who's got a fixed flexion deformity, they can do tendon lengthenings, external fixators, extension osteotomies. In a person who's got a destroyed joint, you can arthropathy, you can do a joint replacement, you can do nerve releases, you can do curettage of the bone cysts, joint debridement, alignment osteotomy, arthrodesis, so on. Patients with HIV, especially if you have, then all these things have to be taken into consideration because this has to be intensified because post-surgical surveillance due to increased risk of infection is a major issue. So you have to be careful when you operate patients with any of the viral infections. So normally what do you do in a patient who's got hemophilia inhibitor? You do an ITI. The idea is to eradicate the inhibitor. You can do prophylaxis. The idea is to prevent bleeding episodes. And then, of course, whenever the patient has a bleeding, you can give on-demand treatment. These are the common strategies that you adopt in a patient who has got inhibitor. But when you have to have surgery, okay, none of these products, either emicizumab or consumab fluticasone, can be used, and only you have to have recourse to is the bypassing agents. So what are the bypassing agents commonly available with us? We have either FIBA or Novo 7. FIBA or Novo 7 can be used effectively to control bleeding episodes. It is used in perioperative, intraoperative, and postoperative management. It is also used for routine prophylaxis to prevent bleeding frequencies, especially also after rehabilitation. And then, of course, prophylaxis and managing breakthrough bleeds in cases of ITA. So these are common uses of FIBA, but in the context of surgery, it is perioperative, routine prophylaxis during rehabilitation, and then managing the breakthrough bleeds. So let us look at each of these products and see how we use them. So what is FIBA? It is a mixture of prothrombin, factor 10, factor 9, factor 8, and there are other coagulation protein factors that are natural anticoagulants that are there in the body. So what happens when you give this FIBA to patients IV? So it acts both on common pathway, it acts on extrinsic pathway, and it acts on intrinsic pathway, and therefore produces a stable clot. There are also these anticoagulant, natural anticoagulants, which are protein C and protein S, which sort of prevents thrombus dissolution and therefore forms a stable clot. So this is a product that uses, you can combine, works on all the three pathways: intrinsic pathway, extrinsic pathway, and the common pathway. What is Novo 7 or factor 7A, activated factor 7A? This is a factor that is got activated factor 7, and when you give this infusion, what happens is that it both acts on the common pathway and in the intrinsic pathway and produces stable clot. So the advantage of this is that you have a tissue factor. Whenever there's a vascular injury, the tissue factor is exposed. Factor 7 activates factor 7A, activated factor 7A stimulates thrombus and platelets, on which is factor 7 activate and produce a thrombin burst, and this localizes the thrombus to a place where there's vascular injury, and it closes the clot and forms a stable clot, because this forms a tight, stable fibrin plug and is less prone to being dissolved by normal fibrinolytic systems in the body. So this is how Novo 7 or factor 7, activated factor 7 acts. So in summary, if you look at FIBA, you look at Novo 7, and you look at the new kid on the block, Hemlibra. For surgery, only two, FIBA and Novo 7. FIBA has been used for more than 40 years or so, and Novo 7 has been used for more than 20 years. Hemlibra, we have got to use only for the past 3-4 years, and the experience is limited. And I will speak also on the Hemlibra and how we have used it in managing patients with hemophilia, in patients inhibitor and hemophilia. The half-life is about 4 to 7 hours in FIBA, very short in case of Novo 7, very long in case of Hemlibra. Infusion time takes a long time for you to infuse FIBA. Novo 7 is just a shoot, it's just a bolus given over 2 to 5 minutes. Hemlibra is not given IV at all, it's used subcute. So it's very convenient to have Hemlibra around when you are planning surgery in patients with hemophilia. Now, surgery is very challenging in hemophilia with inhibitors because it is very difficult to maintain intraoperatively, postoperatively, and throughout the physiotherapy portions, especially for orthopedic procedures, very difficult to maintain good hemostasis. And if you are having a high titer, that's more than 5, the standard replacement cannot be given in sufficient quantities to overcome the inhibitor control during the surgery and after surgery. And many key studies have showed that FIBA, the BPA, bypassing agents, effectively controls bleeding in large majority of patients, 78 to 100% in major surgeries and 75 to 100 in minor surgery. So it's a challenge to treat patients with inhibitor, high titer inhibitor and hemophilia. So how do we give FIBA during surgery? Pre-op assessment, you look at the clinical, you look at the functional and quality of life, you look at the surgical procedure, what surgery you're actually doing, and what is the critical nature of the surgery that happens, whether nerve release or whether you can manage to have a small clot. Because if you're handing a nerve, even a small clot can cause paresis, and therefore you should be careful as to what type of surgery you're contemplating. And this is a constant discussion that you have to have with your orthopedic colleague, time of surgery, how long he's going to take to do that surgery, how long is the anesthesia time, so that you can plan your factor replacements on. So when the surgery is done, you look at monitoring for efficacy and safety, and you can tell the surgeon that you tell me in your surgery within an hour or so whether your expected level of bleeding is normal or it's more than normal. So if it is more than normal, during the surgery, you shoot another shot of bypassing agent, whatever you have, and then take up surgery. So this is a constant interaction that you have to have with the surgeon to see that ultimately there's a good clinical response, and then you can take the patient further for rehabilitation. Now, supposing there's a poor clinical response, you have to adjust the dose, increase the dose, and if there's a failure, whatever dose you're giving of the bypassing agent is not correcting, you have to have the alternate use. Either you can, if you're using FIBA, you use Novo 7, or if you're using Novo 7 upfront, you have to change over to FIBA. So that is the general plan. And you can look at the dose that is given for major surgery, 75 to 100 unit per kg that is given. And we normally use about less than half the dose, 30 to 40 unit per kg. But here we use tranexamic acid. In day 1, we give about 30 to 40 with tranexamic acid, whereas the recommended dose is 75 to 100 units atharly. By day 8 or 21, after the surgery and after the storm is over, you maintain much lower dose, but this is you give twice a day or so for the next 2 weeks or so. And you can even reduce it depending on how good your hemostasis has been, how good the activity has been, the pre-operative state of the patient. Then you can probably taper on to give daily for 1 week, and then every other week, every other day a week, things like that. So you have to play by word of mouth after you put the patient on rehabilitation. So this is the FIBA dosing. I've given you both the recommended doses and what we actually use in our practice. When you come to Novo 7, activated factor 7 of surgery, here it is a little costly, and you preoperatively give 90 units per kg every 2 hours. But what we do normally is about 30 to 40 microgram per kg with tranexamic acid. On day 1 to 7, again, we go down much lesser, 20 to 30 microgram per kg plus tranexamic acid, whereas the recommended dose is something like 90 microgram per kg. This is you give it for about a week or so. After a week, again, you taper like what you did for FIBA, and you taper it over a period of time so that the least amount of factor, that bypassing agent that can be given is comfortable, the patient is comfortable with. Again, when you give FIBA, when you give Novo 7, and the success is not very good, I mean, in the sense that there's more frequency of bleeding, then you have to shift to an alternate pathway, that you have to shift to bypassing agent. I mean, to shift to FIBA. So if you're using Novo 7 upfront, and there's no good response, there's a failure of response, then you shift over to FIBA and vice versa. The third product. In the Haven 1 to 4 studies, when they did surgeries during that period of time when the patients were on trial, they've done something like about 233 surgeries in Haven 1 and 4. In those surgeries, you can see that both major and minor surgery, when you take minor surgeries, they were managed without prophylactic coagulation factor, whereas when you took major surgeries, they have to use prophylactic factor, and approximately the amount of factor bypassing agent that you use, or the standard factor 7 or 8 or 9, much lesser when you compare. So in conclusion, what we have to do is, when you, after surgery, you have to have a good physiotherapy and should ensure a good surgical outcome. Post-surgery physiotherapy is very important to maximize the range of motion. Continuous passive motion is an early post-op period under cover of bypassing agent, and a pre-training bolus of BP is recommended before physiotherapy session and after discharge. Now, sometimes what happens, there's an unexpected bleed. If oozing persists after surgery, check the bolus dose have been given as prescribed, because sometimes you miss the dose, and then you stop rehabilitation program immediately and rest the limb. Check the coagulation screen, platelet, fibrogen. Bring the next dose forward. Instead of being with 8th hourly, make it 6th hourly. Consider increasing the dose. And if the patient has developed thrombocytopenia for whatever reason, you have to give treat that patient with platelet transfusions maybe, and consider changing treatment to an alternate bypassing agent. If you are giving Novo 7, you have to change to FIBA, or giving FIBA, change to Novo 7. So presence of inhibitors increases the risk of uncontrolled bleeding and disability and premature death. Awareness and clinical suspicion and prompt laboratory investigation is critical to establish the diagnosis. Bypassing agents are a cornerstone of these patients, and there's a need for effective protocol, product, risk of infection, and so on. And that is the basic features or facts of managing patients with hemophilia.
Thank you, Cecil. That was a comprehensive lecture. Hello.
Yeah, tell me.
Hello.
Yeah.
So I think one of the things we also need to stress is that as far as surgery in hemophilia is concerned with inhibitors, it's best to avoid it unless absolutely necessary.
Absolutely.
Or you have a lot of money.
Yeah, absolutely.
Yeah.
Because the kind of money is, and the
now
kind
there
of
are two
products that we
questions.
use.
Yeah. Correct. It's huge. Yeah. That's right. So there are a couple of questions not related actually to your lecture, in spite of my repeatedly telling people to ask questions related to the lecture. But anyway, if a child is using emicizumab from the beginning, then is there a possibility that he may develop inhibitors to emicizumab? Anyone wants to take this? Yeah. Tell me, Cecil.
Yeah, I think it is possible. You have anti-drug antibody that develops in a certain percentage of patients, but the incidence is very low. You can develop.
Okay. Can we use Tranexa with emicizumab?
We have used tranexamic acid with emicizumab in a patient who had intracranial bleed, and we did not have much of FIBA at that time. And we have used it without much of a problem. This patient had, I mean, this is all anecdotal. And the sense this patient had intracranial bleed, he had inhibitor, and then we had to, he was on emicizumab on compassionate grounds from Roche. And when we gave him, and when he had developed the intracranial bleed, we had to do surgery. Then he developed, then we found out that he had intraventricular abscess, that is pus coming out from the ventricles. Then we had to give him heavy antibiotics. At that time, we had to give him only little bit of FIBA, that is about 1,000 units every day, along with tranexamic acid. And this patient was there in the hospital for 3 weeks. We had to put an external ventricular device a couple of times. And despite all that, the patient did not make it, but he was there in the hospital, fluctuating for 2-3 weeks. And no time we had, giving low dose of FIBA, we had a bleeding complication. All his complications were infection related, hydrocephalus, fever and things like that, but nowhere ever there was a bleeding. So it is possible to use tranexamic acid, a little bit of FIBA on the background of emicizumab.
Right. Is there an increased chance of developing a thrombosis in such patients if you were to add the Tranexa, theoretically?
Well, this patient was in the ICU. We gave him low dose heparin.
Oh, okay. Oh my God.
Yeah, we had to give, because he was in the ICU for 3 weeks, three months. He was in the ICU for 2-3 weeks, in and out of ICU. Whenever he was in the ICU and he was altered sensorium, we had to give. The moment we put an external ventricular device, he would be awake and he would come to the ITU. And then again, the hydrocephalus would increase. Then we had to adjust the dose of the external ventricular device and then he would again lapse to coma. So during the time when he was in coma and all that, we had to give him tranexamic acid, bypassing agent, and while he was on imosuzumab once a week, and managed him.
Oh my
But I tell you that we never had a bleeding problem with this guy. Bleeding is not an issue with this guy. His only problem was infection and pus in the CSF.
Right. There is one question. I think I'll just comment on it. I am a patient with factor IX deficiency, severe hemophilia. I was positive in the first week of April. I presume that is for COVID. And given heparin and aspirin during treatment, was it intentional to use such drugs during treatment? So, Mr. Sharan, see, first of all, I keep saying, please ask questions relevant to the lecture. However, what I would like to comment, and this is for all patients, is that if you are a hemophilic and you develop any other problem, please inform your treating physician that you have hemophilia, that it's a bleeding disorder, and that you tend to have spontaneous bleeds. Because very often physicians are not aware of this particular condition. After that, the way they treat you will depend on the discretion of the physician. We are in no position to comment on whether the use of the drug was intentional or required or not, because we are not there treating you at that moment. It is always best that the physician treating you in a particular moment decides what treatment you should be given at a particular time. One more question, Cecil. If a kid starts Hemlibra and then stops after a few years for financial reasons, what is advised after that?
You can go back.
Then you go back to the treatment of
Yeah, I think you can go back.
Yeah.
I mean, it's also advisable in the sense that when you're a small child, you give imosuzumab, and for financial reasons, you have to stop the imosuzumab. At least about time, the veins would have developed. Your more child can be more comfortable taking prophylactic at least twice a week, normal factor 8 or factor 8, and probably it's okay, I suppose. No issue at all.
Sure. Right. So with that, thank you, Cecil. We come to the end of this particular lecture.
Actually, yeah. Sir, are you using the injectable tranexamic acid or oral tranexamic acid along with FIBA, Novosin, the small dose you are doing for surgery, major surgery also, na?
We give IV.
Give IV, sir.
IV. You see, because the amount of FIBA that we have is hardly any. 500 units and 750 units, 1,000 units when the patient on Hemlibra. So I think we are comfortable giving IV.
Yes. After, sir, you were commenting something. Yeah.
No, we recently had a patient, two brothers who were on Hemlibra post-trial access. They had an accident. One brother had a subdural bleed, but he was Glasgow coma scale was 15. Neurosurgery said no intervention. We did not give him anything, and he fell through. The other brother had hepatic tear, renal tear, bilateral renal tears. So we managed him only on him. We had only 18 milligram of Novo 7. We just used it in first day, and we just managed him with IV tranexamic acid. He was in the hospital for 3 weeks. He was on low molecular weight heparin prophylaxis, and he was on a weekly 1.5 milligram kg of Hemlibra, and we continued that. And he fell through. He was there in the hospital, but IV tranexamic acid with Hemlibra, I think that saved him because we didn't have much fever or Novo 7. We are sending this as a case report because he underwent 5 surgeries in 3 weeks.
Oh, wow.
No FIBA, no Novo 7 was used.
Right. Okay. There is one more question, again, not relevant to the lecture, but we'll quickly take it. A person with hemophilia has hematuria. What is the safety of use of tranexamic acid? Dr. Karim, we do not recommend the use of tranexamic acid in patients with hematuria, because you may go into an acute kidney injury, you may develop with that. So by and large, I would avoid the use of tranexamic in hematuria. Anybody wants to add anything to that?